My name's Kendra. I am a therapist at Frontier Health, work in children and youth services. Also, I'm a PCIT trainer and coordinate some of our programs we have there. And we're going to talk about protecting childhood, Frontier's approach to preventing and treating child maltreatment.
Sure. And I'm Melissa Birdwell. My title is Director of Tennessee Outpatient Services, but like I tell most people, what that means is that I'm over therapy services, which includes children's services, adults, and IOP.
So I know all of you got your phones. I've seen them. So
we're going to give you permission to use them.
Yes, to do a fun thing. Something at least I think it's fun. If I can now get it to do the. Okay. Well. So. That's the wrong button. I'm gonna have you grab your phone and scan this QR code or go to menti.com and put that code in. So we want to get an idea of who's in the room. So that first thing on your phone, it should let you pin what part of the state you work in.
Oh, I've never done that.
It's approximate.
You might be in multiple counties. So
Yeah.
It's okay.
The general section of the state.
Yes, if I want. It's not like kindergarten coloring. You don't have to stay in the lines, right?
Does everyone put theirs on there?
Right.
All right. So it looks like we are a little heavy on one side of the state. That's good. That makes sense for why you're here. So our next question, what agency or group are you affiliated with? Who's your employer? Last question. Your professional role. Awesome. So that's going to help us figure out what we need to talk about and focus on our presentation, who is in the room. So thank you guys for participating in that.
And yay, social work. Gotta stick with my social work.
All right.
Okay, so let's talk about what we're going to do today. So we want to be able to identify risk factors of child maltreatment. Then on the flip side, we want to be able to talk about the 5 protective factors. And then finally, funneling that down into evidence-based interventions that will most impact those areas. So I can.
Did you go? Yeah, down.
Yeah. We got it. So First of all, we got to start out with what is child maltreatment. So I included the World Health Organization's definition, which you can kind of read, but of course it does say abuse and neglect for under 18. And what I like about their definition is it includes things that lay people would assume, which would be the physical and sexual abuse. If you were to ask people on the street, they'd probably name those things, right? But it also includes other things like neglect and negligence, and especially the emotional ill treatment, because I don't think we always think about those things. So I'm glad they put that in there. And then, of course, the commercial or other exploitation, I think there is a big move to educate on child trafficking. And so I'm glad that that's a piece. And of course, they talk about then the harm that comes from that, and specifically mentioning that the relationship is one of responsibility, trust, or power. So it's not the two kids on the playground, that's more equal, but it's a power inequality. And so I know you've seen this statistic before here at the conference, but again, in 2022, Tennessee had 6,834 children who were confirmed by CPS as victims of maltreatment. I think we do a really good job of identifying those, but I would also highly suspect that just because those were confirmed, there were others who weren't, that we missed somehow. So that's a huge number. Even one is too many, but that's still kind of big. And of those, 40% were in the age range of 0 to 4. So you can see how it's kind of skewed by age, with the most being the youngest kids, and then 24, 17, and 18% for the next age ranges. There we go. You got to also hold it right up here. So if we talk about child maltreatment, now that we know what it is, what are the impacts? And it doesn't just impact the child. It doesn't just impact the family. It's really the child, the family, and the community. Okay, well, with what kind of things? Certainly a lot of loss of education. We were talking earlier today about truancy issues and things. Loss of workforce, definitely poor health. Trauma symptoms, we know PTSD and other things, substance use being a big part. And then we went into this field not because we like to talk about numbers, not because we certainly like to talk about money. Sometimes we have to, that is important. There is an overall cost of the care. And it's estimated that the impact of substantiated claims for the abuse and neglect is between 3.33 and 4.97 billion per year. That's huge, right? So when we talk about early prevention or early intervention and prevention, how does that help? Well, we're going to increase the labor force participation. In other words, we're going to have a healthy community who's going to be able to actively participate. Obviously, improved health, less substance use disorders, hopefully less incarceration with that as well, and then less state service demands and greater life expectancy. So we're creating a healthier society who's going to live longer and be able to participate in all of them. So again, not that we like to talk about money, but it does speak to us. So it's financially impactful as well, because for every dollar invested in infant and early childhood programs for mental health, you get $3.64 back in prevented treatment later in life. So the question becomes, do we want to spend that $1 now? Or do we want to spend the $3.64 later? Of course, that doesn't sound like a big difference, but you multiply that and you're seeing a huge return. So that kind of spoke to me. So we said we were going to talk about risk factors. We have to figure out what is the cause behind these things. So for the child, the risk factor we saw earlier at 40% was being younger than age 4. We were just talking earlier about how difficult it is to have those newborns and those 2- and 3-year-olds, right? It is tough. It's very stressful. So I think that's one of the reasons that age group is impacted. Plus, they can't really do a lot for themselves. They can't get themselves out of a situation even temporarily. And then having special needs. again, when lay people probably hear special needs, they're thinking maybe developmental, but I think it can really be anything that's a special need, developmental, physical, mental needs, any of those. The perpetrators also have risk factors. Substance use, which we know, especially in our area, unfortunately, is quite high. Mental health issues, lack of parenting knowledge, just not knowing what to do. A history of their own abuse, maybe currently, we were talking earlier about domestic violence situations, things like that. Having low income can put people at risk, incarceration, that isolation. We work in a lot of rural areas, so isolation can be very difficult. Domestic violence, we mentioned. Poor communication, not having good communication skills with others. High stress. I think all of us could even understand that when times get stressful, we're just not at our best. Imagine when that stress is day in and day out. Certainly having their own history of childhood abuse, because again, that's what they know, that's what they've grown up with. And then having more than 2 children, because again, that increases that stress level for the family. And then with the community, there's also community risk factors. So violence and crime, particularly in an area, high unemployment, access to the substances, and low community involvement from residents. So a community where people are not pulling together, where you don't know your neighbors. Few activities for the young people, so they don't have things to do and healthy outlets. Unstable housing, people are moving a lot or they just don't have housing. And poverty with limited education and economic opportunities. And to me, that also talks about hope. And when people lose that hope because there's not a lot of opportunities available to them. So far, the news doesn't look that great, does it? But let's talk about the good side. So what are the 5 protective factors? What can we do that are going to be factors that help people? One being social and emotional competence. So with that one, we're talking about the child has a positive relationship with that caregiver so that they're bonded well. Knowledge of parenting and child development. We said that if people don't understand or have the skills, the parenting skills that are necessary, it can be a risk factor, but having that knowledge, having the appropriate expectations for child development, so we know what a 3-year-old's capable of versus a 10-year-old, can certainly help us and be protective. Resilience. So parents who are able to be resilient despite the fact that they have all of these stressors that they may be facing. You can imagine a parent who can't regulate themselves and their own emotions is going to have a really tough time regulating that child's emotions and helping the child. So when they are able to do that and they are resilient, that's going to be a protective factor. And then concrete supports. So thinking about those basic needs, are those being met? So your housing, your food, your clothing, all of those needs. I think about Maslow's triangle, right? Those bottom levels, are we meeting those? That's the concrete support we're looking for. And then social connection. So we said isolation can be really difficult. So parents having the access to networks of friends and families and people that are there to support them can be really important. I know when I was in undergrad, my very first psychology class, Psych 101, that we all have to take, right? My professor, Jonathan Heights, said, if you come the last day of class, if you make it that far, I'm going to tell you the meaning of life. So, of course, we stuck around because who doesn't want to know the meaning of life? And so on the last day, sure enough, he told us, he said, it's 2 things, R and C, relatedness and competence. And that's what you see here. Right? So that social connection, the relatedness, and the competence, the building of knowledge, of parenting and development. So I think he was on to something. So you can remember that as you're thinking about those 5 factors, the relatedness and competence. Okay, so we know what the risks are. We know what is protective. How do we address those? Because we want to boost up those protective factors. We want to help people. Well, in community mental health agencies like Frontier Health, we have several things that can impact those. So we have infant and early childhood mental health treatment so that we can take care of, we said that one factor is mental health treatment. We can take care of that one. Substance use treatment. So again, one of the risk factors for the perpetrators was substance abuse. We can cover that through outpatient or IOP. General therapy services, case management. So if we got to meet Maslow's hierarchy of needs at bottom level, that's exactly what our case managers can do. Parenting classes. It's a positive protective factor if they have the knowledge. So let's give people that knowledge. And criminal justice programs. So we want to maybe prevent criminal justice involvement, or at least work on the recidivism rates if possible, right? Those were other factors we mentioned. Again, bottom of the triangle, we want to work on housing programs. We want to have housing for folks and help them get involved. And then employment and educational specialists. We talked about hope, and when we lose hope, when things are not available to us, we feel stuck. We don't want people to feel stuck. We want to help them to feel like, yes, I can go get that degree if I want, or I can finish high school, or I can get my GED. I can get a job, and people are going to be there to support me and make sure that I'm very successful in my job. Okay, well, that sounds good, right? We can do all these services. That's wonderful. But you might be thinking, how do you know they work? And I could tell you, well, I saw 5 clients and they all got better when I did this. Well, that's great, but that doesn't really tell us anything, does it? Not particularly. So instead of just saying I saw 5 people that got better, we look at evidence-based interventions. What are evidence-based interventions? Well, specifically, they're programs, practices, treatment, models, whatever you like to call them, that have definitely been studied. They've been proven. It's not just my 5 people who happen to get better. We're talking hundreds of people over time. You can talk about evidence-based interventions with various disciplines. It doesn't just have to be mental health. Of course, it can be medical fields and lots of other fields as well. But when we're talking specifically about child welfare, or if we just want more information about evidence-based treatments, the place to go is the California Evidence-Based Clearinghouse. And I've included the website there. A little bit of history about the clearinghouse. So the California Department of Social Services, or their DSS as they call it, provides a leadership in targeting efforts to improve the lives of their children and their families. They were seeing a lot of problems and they said, we've got to do something, but we got to prove it's going to work. So they said, how are we going to go about that? So they partnered with the Chadwick Center for Children and Families in San Diego, and they created a database, which is searchable, of all the evidence-based treatments that they could verify. And they've included information. If you go look at it, you can see not only the name of it, but you'll be able to see a little bit of a description, who it's for, what it does, etc. They use a rating scale for the models and the tools and things that they have listed. And when you think about just a rating scale of 1 to 5, that doesn't mean a whole lot. But when you look at the criteria that they have to meet, you can see it's really intensive. If you see something that's on there, it's very well studied. To even be considered for a rating, a model has to have a book or a manual with it. It has to be in one of the topic areas that they cover, and that is pretty broad. They do cover things like mental health, welfare, behavior management, parent training, etc. So that one's not too hard. But they also have to have positive outcomes, and those outcomes have to be from research studies, which are reliable and published in peer-reviewed journals. So that adds another layer, doesn't it? But they're not done there. That's just to get a rating. Then you have to look at the actual ratings. So the ratings range from 1 to 5. A 5 is considered concerning. And a 5 would be that maybe there's been a negative outcome in a study, might even have indicated there could be harm caused by that particular model, all the way up to a number 1, where a number 1 is well supported. And to get that designation, they also have to have 2 random controlled trials that produce positive outcomes. And those outcomes have to last an entire year after the treatment ends. So you can see this is going to take a long time for something to actually get to that designation, right? So you can rest assured if you go there and you see something with a 1 rating, that this is definitely a reliable treatment that's going to work for you. For my 5 people I was talking about, right? We can rest assured that there's something to back us up on that. So I think that that's very helpful, and I hope if you haven't already that you will check it out. So we started with risk factors. We moved into what are the protective factors. We talked about general services that can help increase those protective factors and decrease the risk factors. But now, then we talked about what evidence-based treatments are, but now let's look at some specific evidence-based treatments that we can use that will specifically help with the kiddos.
So before we jump into the specific things that we've got, I want you guys to think about the word resilience. We use that word, we've heard it hundreds of times in the past 2 days, right? But thinking about what it actually means, it's a really hard word to define. So if you think about someone you've known who you would consider resilient, they first have to have had something not great happen, right? You can't be resilient unless something has happened first. So when they went to study resilience, they were like, all these different disciplines have different definitions. How are we even supposed to like come together when everyone defines it differently? So they came with, I wish I could like magically quote this definition for you, but I can't. But Ann Maston, her work on resilience was super neat because she took all of these studies about resilience, gathered it all together, and was like, we don't really know what it is. It's this weird magical thing, but it's also ordinary. So she coined the term ordinary magic. It's out there all the time, everywhere, but for some reason, it's so amazing. So all the things we're going to talk about here have some ordinary magic in them in some way. So the first one we're going to talk about is nurturing parenting. Nurturing parenting is an evidence-based approach to parenting education. We talked about parents need to know what to expect from their kiddos. Their 3-year-old can't tell time and can't make a whole chicken dinner, right? But if they're expecting that, that's not going to work out too well. So making sure we know this is what is age appropriate. So we're going to teach them about education on child development, give them skills that are appropriate for them to use for that age kid. We're also going to help them with behavioral interventions. Putting a 1-year-old in timeout, that's probably not going to be very helpful. They don't know what they've done. They don't understand that. So figuring out what it is they can do for their specific thing, it tailors it to their specific kiddos. Usually these are small groups. It can also be done individually so that we can really make sure we're taking that family into account. Some of the core principles that are used is empathy, self-worth, empowerment, discipline, and attachment. So when they came up with this, they're like, no one's listening to the parents. We're just like out here telling them all the things, not paying attention to what's actually happening. We need to hear them. We need to respect them. We need to take what they're saying and help them in that specific thing instead of just quoting a book to them, because that's not helpful. So they really want to hear from the parent, what's going on? How can we give back so they can implement it successfully? So by doing that, we're addressing the risk factors, parental stress, mental health. They come in with their own things. We all got our own things. We come in with it, and then they're able to say, hey, is this what's going on for you? How can we help with that in addition to the parenting stuff that's going on? They're also addressing intergenerational patterns of abuse. So we all had a childhood. We grew up thinking things were normal, and then we got older and we're like, what? Not everyone drank from the hose in the backyard. So things that we may think are normal may not be typical in the rest of the world. And we don't know until someone tells us that, or until they give you weird looks when you're telling a story about your childhood. So identifying those patterns and helping them figure out this isn't what typical families are like, and let's help you figure that out. That way you can create that environment for your kids. Promoting those protective factors, giving them that information, concrete support. They're coming in with exactly what their issue is. We're helping them with that right there in the moment. So doing this really allows for us to build on the idea of resilience, because resilience is community. It is the things, people, and factors around us. It's not innate in one person. It is what is around each person. There's resilience individually. There's resilience as a community. There's resilience in culture. It's grows, and it's whatever environment you're in that helps us be resilient. Another one that we used, family linked respite services. So these are things that Frontier has, but these are things that are across the state of Tennessee. So it's not just specific to Frontier Health. These are grants that are out there and programs that are provided. So just because we're talking about what Frontier has doesn't mean they're not out there other places. So Family Link Respite Services. This is a service where the parents are able to bring kiddos to a program for a few hours one day a week, and maybe go to the grocery store without someone tearing all the marinara sauce off the shelf. Be able to have a minute to go. We've had parents go take a nap in their car. They get a minute to do that. Maybe it's to go visit a friend so that they can get that social connectedness. Maybe it's so they can go to their own therapy appointment and take care of themselves. So Family Links Respite Service really provides that rest and relief for parents. Also for kids. They're around their parents a lot. And if their parents real frustrated and has a lot going on, kids are going to experience that. So if we can give them a break, let them have fun, learn something cool they want to learn. And then when we pull people back together, even after a few hours, things are going to go better. It's going to be smoother. Everyone's going to have had a breath, had a moment to kind of chill out. So also enhancing emotional well-being. So we talked about how parenting is hard. I'm not a parent. When I hear y'all talk about being a parent, that sounds so stressful and overwhelming. So I can't even imagine. This gives the parent an opportunity to lower their stress levels and improve their own emotional health, because they got to be put together to help their kids be put together. So they're given that opportunity, and parents have reported feeling more balanced, better equipped to handle challenges after they've been able to use a respite type service, where they get a break and their kids get a break. We're strengthening the family dynamic. When parents have the opportunity to take care of themselves, they can return to their caregiving roles and be more patient, have healthier interactions, and have stronger relationships with their kids, family, and others in their circle. Promoting social connectedness. This can give parents time to engage in social activities, but it also gives the kids that opportunity. Maybe these kids that they're in there with are not from their school district. They're from a different school. They have different life experiences. When they come in, we ask them, what's a goal you have? For some kids, they may say something serious like, I want to work on my anger. For other kids, I want to learn how to tie-dye a shirt. All right, that's your goal. We're going to do it. So they get different experiences. They are able to interact with people from maybe different cultures, different schools, different areas. That helps them get more social connectedness as well. Last part here, support long-term caregiving. If parents have just a little bit of a break, even if it's a couple hours once a week, they're going to do better long-term. Gives them that opportunity to get away. Reduces caregiver burnout, reduces the likelihood of child maltreatment. They're able to take that time. And that's the goal, right? We want to reduce the child maltreatment. Yes.
Sorry. Well, like this, supporting long-term care unit, do they have to be enrolled in another one of your programs to receive these services?
They do not. They do not have to
I'm thinking
be.
like the rural caregiver program, they have a lot of grandparents out there raising grandkids.
Yes.
I know a lot over there in the upper Cumberland that, they need some kind of service like this because they're.
Absolutely. Yeah. No, they do not have to be enrolled in Frontier Health Services to receive this service. It's completely separate. That's a great question. So, family links respite, giving that break to everyone is important. So moving more into therapeutic things. So we had like the parenting class. It's not necessarily a therapeutic thing. Family links respite, more of a break. It's not a therapy. Moving into therapy models. So dyadic therapy models are really set to work on those relationships with the parent and child. It's a parent and child only. It's the dyad that we're working on. And it gives the parents the skills and the opportunity to communicate, teaching them how to communicate differently, more effectively, and have a better understanding of their kiddo. So parent-child interaction therapy is an evidence-based therapy for kids 2 to 7. It's got an asterisk there because there's also parent-child interaction therapy for toddlers. So 1 to 7, really. These are our kids with behavior concerns. These are our kids. We know them when they walk in. We had one last week screaming downstairs. They hadn't even made it to the front desk yet, saying all the words you don't want a kid to say. Like that. That's a PCIT kid. Those are our kiddos that we really are able to help have those extreme behaviors. CPP, I don't know that anyone's really talked much about that in the past couple of days. So child-parent psychotherapy is an evidence-based therapy for kids 0 to 5. When they first told me that we were going to do therapy with 0, like kids that weren't even 1, what does that look like? Are you putting a baby on the couch and we like look at each other? I don't know what that is. And then I learned about it and it's actually really cool. So no, we're not sticking a baby in a carrier on my couch to talk to them. Kids learn through play.
Yes.
They share through play. They tell us so much cool stuff about their life through play because they don't have the language for it. So we're taking these itty bitty kiddos and we're working with them. And this is for people who the child, caregiver, or child and caregiver have experienced trauma.
And I will add to what Kendra was saying with that. So I've worked in this field for 24 years. And when I first started, everyone felt like she was just describing infants. No, if somebody called our office and they said, how old is the child? Well, it's a child who's under 5. Well, I'm sorry, we just can't do anything, right? At most, we might could do RIP, but that's it. Therapy? No, that wasn't a thing. They would have laughed at you, right? But I will say, there has been so much work in this area over that time that now we understand that importance. We know why we need to do this work and that it's not setting child on a couch, which we would have thought back then, right? And the state of Tennessee has done so much to provide the trainings and the effort and to get people on board with this, that it has been just amazing to see over that length of time just how far we've come.
What's the youngest you had that type of therapy?
So I've seen an 8-month-old. As you can imagine, we're working a lot with the parent. The child's our identified client. We're working with the parent. And it was a really sad situation. It was a combination of all the factors we talked about. Parent came in and said, I don't like my child. They're kicking me in the head in the middle of the night because that's what my abusive husband used to do. And he knows that. And he's doing that to me on purpose. We know an 8-month-old isn't on purpose kicking her in the head, right? They just have wild feet that do things. So when we were able to process through that a little bit and teach what's age appropriate and then what her history was and get her to engage with the child. Now we're not going to be playing Legos with an 8-month-old, right? Like that's a choking hazard. So we're engaging differently. Puppets, toys, soft farmhouse things like that, where the parent can play with the kid and the child learns that this is a safe interaction for me.
I guess that's your answer part of my question too, because I was gonna ask if during this day, in the CPP, do you introduce that social emotional connection with that young adult, that interplay, you know, talking to, reading to, singing to, those social emotional developmental skills?
Absolutely, yes. Yep.
Kendra, can I ask, so I've heard a little bit about, like the state baby courts and how they use, some of them use CPT. So I wonder if you could talk about that a little bit about, I don't know, like and I know there's a state baby court in Johnson City.
Mhm.
But yeah, do you provide both PCIT or CPP for families that are,
So Safe Baby Court was really it really is a great fit with CPP. Those kind of like hand in hand go together.
yeah,
These parents, something's happened, they end up in a court situation.
yeah,
We don't want to take their kids away because it's just, they need help.
yeah.
We don't want to penalize them. And so CPP is a really great option for them. And we'll go into a little bit more about CPP in just a sec. I've got PCIT first,
You're
and I don't want to get mixed up.
That's to keep you engaged.
No, it's good.
So a little more in-depth information on PCIT. This is kind of a weird thing to explain to parents when you're like, you're going to be in a room with your kid and I'm going to be somewhere else. I can see you and you can't see me. So we give the parents a bug in the ear, makes them feel like they're in the FBI, and we get to talk to them that way. That way the parent can hear, the child cannot hear what we're saying. So the parent can get the feedback from us. We're helping guide them on what they're doing, how they're interacting with their kiddo. Even if that's we're just going to ignore that before they jump in and say something, then that can help improve that communication. 2 phases. The first phase is child-directed interaction. So this is the kid's favorite part because they get to come in and it's their playtime and they have so much fun with their parent because everything is following kiddo's lead. We're not telling them what to do. They don't have to pick up the toys when they're done. Room's going to be a mess. The second part is the parent's favorite part because at this point, we're teaching the parents how to set boundaries and set limits. And we're telling the kid what to do. Please put these blocks in this bucket. They don't do it, there's a consequence. They're going to timeout. They don't stay in the timeout chair. We have a backup solution for that. So they're going to end the session with complying with whatever the command is. Kids learn, this is the only thing that's going to happen. If I don't follow the rules, I'm going to go to timeout. There's no way around it, no way out of it. That's what's happening. They got to do the thing. Reduces aggression, defiance, tantrums, increases positive behaviors such as sharing, following directions, and it improves parental confidence and consistency in managing behavior. When you're out and you've got a real frustrating situation, you're like, no, we're not doing that right now. If you say that again, you're going to be in timeout when we get home. By the time you get home, they forgot, you forgot, there's no consequence. So this makes sure that it's the exact same situation happening every time. Every time there's a behavior, this is what happens. This is how long it happens, and this is what the kiddo can expect. Okay, so CPP. It's trauma-informed, attachment-based. So we're really working on that attachment, emphasizing the importance of the secure and nurturing attachment for the developmental level of the child. Developmental level from a 0-year-old to a 5-year-old, there's a lot there. So we're helping them figure out what exactly is your child's developmental level. And not all 5-year-olds are on the same level. And helping parents understand that too. They may have read a book about what a 4-year-old's supposed to do, but that may not be what their 4-year-old's doing. So this really integrates a lot of different parts: psychodynamic development, trauma, social learning, cognitive-based therapy type things. Enhances child caregiver relationship. So we've got both the parents there, or both the parent and the child there. The first session, we're doing an intake. The second, third, sometimes fourth session, we're just meeting with the parent. What's your history? Tell me about your childhood. What's something that your parent did that you remember to this day being great? And then we do what's called angels and ghosts in the nursery. So what happened when you were young that you remember that you never want your kid to experience? What happened that you do want your kid to experience? And that kind of gets to some of that cultural what traditions and things did you have that you want to bring into your child's life? It's really mindful about what do you want to bring in and what do you want to leave behind and not move forward. And then we move into helping the parent explain what's going on to kiddo. So we create a triangle that talks about you're here to see the therapist because something really scary happened and we're going to be here to talk and play about it. And that gives them the safe space if it's okay to play in here, because sometimes they're told you don't tell people what happened. And that's for real. When your mom tells you you don't tell someone, you don't tell someone, right? So that gives them permission to share, talk about it, play about it. And then the therapist kind of becomes the third wheel in the room while the parent and child are playing. And therapist is kind of interpreting what's going on. Oh, you notice how he put that baby in the bathtub, and like based on their story, we're able to get an idea of what that may mean and help the parent understand what the play means. Because kids are telling a story. We just don't always know what that story is, right? So helping that bond, helping parents understand what their kid's telling them. They can't sit down and tell them about their experience, but they can play about it. And we're helping parents understand that. That answer your question?
It does. Yeah, I
Okay.
see why this is super useful for, yeah.
Awesome. So both PCIT and CPP have all of these things coming into them that match up with our protective factors. We're focusing on strengthening the caregiver and child relationship. We're giving them positive feedback. We're enhancing caregivers' needs to sensitivity of children's needs. So we are helping the parent figure out what does that mean and how do we meet that need. They don't come with a manual, so we got to figure that out kind of in the moment with them. Also going to help promote emotional regulation. When our parents are regulated, our kids are more regulated. So that helps the parent help the child. Also helping kiddo develop coping skills. You're like, how does an 8-month-old have coping skills, right? But coping skills can be super simple, like rubbing kids' back when they're crying, helping them learn how to self-soothe, because they don't learn that on their own. They have to learn that from somewhere. And so we help teach them that. Also fosters trust and communication. They know that a parent is a safe person now. They know that things are predictable. They know that they have a good spot where they can share, even if that's through play. Any other questions about CPP or PCIT?
I did have a question.
Yeah, I saw the question coming.
It's really interesting to me too, especially when you mention like behaviors. I know, just, I was an educator in the past, so like just some parents don't understand developmental behavior and they don't know how to deal with that. So, like in certain situations, have you had experiences with at that younger age group and the parent being in denial almost as far as like, you noticing like just developmental delays or behavior issues related to that? Like, how are you dealing with that in that type of setting?
So it's really hard to think about my child isn't perfect, because children are perfect, right? They're amazing, beautiful little things that have been created. And so the idea of maybe there's something going on or something wrong with my child is terrifying. So helping them understand, okay, maybe there are some challenges. Maybe there are some developmental delays. Maybe you are expecting developmentally appropriate things from your 4-year-old, but your 4-year-old's just not there. How can we adapt? How can we help with that? How can we provide the parent support and additional services so they can cope with that? Because that's a big thing that's going to impact them potentially long term. So making sure that we're able to meet them where they're at with whatever they're bringing in. Sometimes we can get in this cycle of, oh, they're going to come in for this session and this is what we're going to do. But when we plan ahead too much, we're not meeting our parents where they're at and our kids where they're at. When they come in and they've had this big thing happen, we can't just be like, well, I know that happened, but today we're going to work on. We're not matching up with what they need. So really meeting them where they're at and what's going on in their life and what's happening in their moment. We're going to try to pull that in to what we're doing in the model. But I feel like that's the most important part, is being that person that they know they can trust and come back to. feel like that almost answered your question, adjacent.
Have you had like, any studies on like the outcomes of the families that you have had? Any-
I do not have any of that today. There are outcome studies out there, and CPP is evidence-based, so it's got information out there. I just don't have, I don't want to make stuff up.
I mean, CPP is new to me, so I was like,
It's in Title 40, I just checked, it's promising. So, yeah.
Interesting.
Yeah, it's a cool thing.
I would call even having our own data promising just because we needed technology to catch up with us. And 2 years ago now, we got a new electronic health record, but only within the last couple of months have we tried to figure out how to make it so that we can pull data from it to say we did this evidence-based treatment or this one and that kind of thing. So I hope eventually we'll be able to run reports and say we did this many sessions with this many people and this many successfully completed. So it's coming.
I can see they're really helpful with that younger age group, so.
Yeah.
Yeah, I'm interested in research.
And kudos for getting that EHR, like, it's, I know that's a lot.
Yeah.
So
It's a challenge. So, talking about CPP, PCIT, especially PCIT toddler, we're in this weird, like, kind of still emerging space of working with the little babies in therapy. And it's new and sometimes uncomfortable. So, what is infant mental health? So, according to AIM High, which I'll talk about in a second, infant mental health is helping social and emotional well-being and development of children birth to age 5, as well as the quality of relationship with caregivers. Encompasses the development of healthy attachments, coping mechanisms, the ability to regulate emotions. And it emphasizes the importance of secure attachments, nurturing environments, early intervention to support healthy development. So all of those important protective factor pieces are in infant mental health. And babies do not exist in their own little bubble. As adults, we could theoretically, if we needed to, exist alone. We can be self-sufficient. I wouldn't enjoy that, but some people may. But a baby can't. If there's no one to take care of it, it's not going to survive. So babies are not a thing in themselves. They exist in the context of a family, some kind of environment around them. And that is what we have to support infant mental health and the wellness of babies. Any questions about that?
Have you found this, like, explaining or talking about infant mental health? Like, starting this work was the first time I had really heard that term. But do you find that challenging to talk with parents about, or like explaining like why it's important to consider mental health? Because I know people will say, well, they won't remember anything anyway, but it's like understanding that your body remembers before, yeah.
Yeah, I've even done news segments about this and things because I know that we need to get the word out that no, it's not a bunch of baloney. And yes, it is important work, and here's why. So is there still a stigma or almost around that? Yes, but that's how we're trying to combat it, is just education, both at the individual level when people come in the office, or all the way up to, like I said, trying to spread the word far and near.
So, because it's important to spread the word of infant mental health, because so many people haven't heard of it, I want to talk a little bit about AIM High. So AIM High is the Association of Infant Mental Health in Tennessee. They have a table out there in the atrium. If you haven't checked them out, you should do that. They really focus on empowering professionals and family to foster strong, positive relationships, provide resources for optimal early childhood growth. And these efforts aim to lay a solid foundation for lifelong mental health and resilience. So we start when they're little, and hopefully they could grow up and be awesome people like the rest of us. So what do they do? Because that's kind of a big question. AIM High does a lot of different things. Their website is packed with so many things they do. So I tried to like funnel it down into some basics. So they provide endorsement. for those who work with kids. They have several different types of endorsement. There is infant early childhood education, mental health. There's endorsement for people who do policy work, endorsement for mental health professionals, endorsement for home visitors, early childhood education, all kinds of endorsement pathways. Getting endorsed is hard work. There's a lot of things because they want to be able to say, yes, this person knows their stuff. So if that's something you work with, something you're interested in, I definitely encourage you to check it out. They also have a directory of all the endorsed professionals. And Tennessee, I think, is the second largest mental health community in the US. I think Michigan is first, and then we are second because Tennessee has invested in this. They've said this is important and we need to do it. So they have been helping to fund people becoming endorsed by covering fees for applications and that sort of thing. So if that's something you're interested in, now's the time to look at that. Well, they're still doing it. They do so much professional development. You go to their website, there's a training section. It's free. They record the things. You can go back later and be like, oh man, I wanted to get that, but I wasn't on when they were doing it. I was busy. You can go back and look at it later. And there's a wealth of information out there. So many different people with so much knowledge. And it's not just for mental health professionals. It's for everyone. It's for parents. It is for educators. It is for anyone who's interested in this kind of stuff. Training and outreach goes right along with that. Technical assistance, if there's something you need help with, you can call them up. They have this really cool thing called the warm line that they're trying to push out. And so before I talk about warm line, I have to explain reflective practice. In infant mental health, it's really important to be aware of our own self and our own stuff, the baggage that we come with. And that's true for parents, that's true for professionals. So they encourage reflective practice. Reflective supervision and consultation is really big in the infant mental health world. You meet with someone, you talk about your situation, you get a different perspective, and they're like, hey, do you ever think that maybe like your experience, things that you have, biases, may be impacting how you're working with this family? So it really makes you kind of think extra hard about how you're engaging with others. So the warm line is for like DCS workers, foster parents who are really struggling with something. There's this weird case situation. They don't know what to do. You can call up the warm line and they will consult with you. Super great because it's not part of the state. So you're not like dealing with the legal part of the DCS stuff. It gives an opportunity to have someone hear it, talk it out, get some other ideas. So I think that's really cool. They also have a clinician directory resource. So this is where you can find those CPP providers and PCIT providers, TFCBT providers in your area. It's got a map of Tennessee. You're able to pick where you're at and find the list of those people near you. Okay, next.
Okay, so we've talked about these are the factors, going down to here's general services, on down to here's specific treatments and things that we can do. So maybe you're thinking, okay, well, this sounds great. I'd like to bring that to my agency, or maybe there's pieces we want to do. And how do we do that? What's the experience like when you've implemented some of these things? And some of this, you may have had similar experiences, even if you don't do the exact things we were talking about. But we've experienced some challenges. Number one, I know I keep saying we don't talk about money, and then I keep bringing up money, but grants. A lot of the trainings and things that you do around some of the evidence-based treatments are through grants, and we all know that that's not something we can be guaranteed, right? Grants are time limited, so you got to get it in while you can, and you hope that you get that grant renewed, but there's, again, no guarantees for that, so it can be a bit of a challenge. Then there's the time and cost to train your providers. Some of the trainings are very lengthy and very expensive. So we're talking about a year and a half to get somebody completely trained in a model. We're talking about a lot of days of missed work in a sense because they're not doing the regular job. They're at the trainings. So that can be costly because not only are we paying that trainer, but then we also are losing whatever money they would normally be generating on that day for the staff. We also have to think about getting appropriate referrals. Not every child is necessarily appropriate for every model, so you have to think about how are you going to tease that apart? What method are you going to have for placing people in the different programs? And kind of like we were saying before, how do you get the word out too, right? How do you educate people about these things so that they can refer appropriately? And then there's the fact that it's weekly. Most of these treatments are designed to be weekly. And so that can be quite a challenge, one for the clinicians because they're very busy people and have schedules, but also for the families. This is quite a time commitment for a family who's got so many other things going on. And so trying to work with them and make this a doable thing that they're willing to commit to and able to commit to can be difficult. There's also, again, speaking of the fact that they need to be weekly, there's the idea of fidelity to a model. It's one thing to say, yes, I do that model, but are you doing it to fidelity? Are you following all the rules and regulations, so to speak? So that can be a challenge as well. But there are successes. So what are the good things that come of it? Ideally, we're helping a lot of people, and that's good, but then there's other things that are very helpful as well. One being partnerships. So we have very close partnership with the Center of Excellence in our area. That has been immensely helpful. They help us with trainings, consultations, and things like that. They do a lot of collaboratives. And then that leads to another part of the partnership. Because we've been involved in collaboratives, we now know people across the state who are doing similar work. So if we have questions or even if we have people move out of our area and we need to transfer the case, we know who to call. It's like little communities that have been built around these things. So that's been really great. Developing within agency training structures. So when possible, we try to develop our own trainers. People like Kendra, who is a PCIT trainer, so that we can continue and have that sustainability because we can then train our own staff that way. And then again, sustainability with in-house supervision support. So we try to make sure that when people are trained in a model, they have follow-up afterward with somebody else who's been a trained supervisor in that model. So it's not go to the training, okay, you're done, you get the seal of approval and you're out there on your own. They still have somebody to go to, and they still have opportunities for that extra supervision specific to the model that they trained in. And lastly, too, I would say it's a success to get the support from upper management. We've been able to do that. And without that, I don't think we would have been able to do these models because you need the buy-in and support of the upper management to get the time to do it. Again, to have that ability to pull people from their regular duties to do the models. So that has been really helpful. We actually have in our strategic plan for the company that we are going to train people in specific models. If you ask me, the goal is going to be 100%. We don't have it as 100, but that's my ideal. That 100% of our therapists are going to be trained in at least one model. Not everybody is a good fit for everything or has that interest, but that 100% would be trained in at least one, and we are pretty close. So I'm glad to see that. So we're very supportive. All right. Gotta use my clicker again. All right, any other questions that you may have? We've answered some along the way, but if you think of other things, we're happy to talk about it. Yeah.
Don't be sorry.
Sorry for a question.
We did like a little research with like that area, Washington County, area a few months back. One of the things I heard was like, it's hard to find housing for families. And I did see that you have that within the precinct. I'm just curious to know, like, are you at capacity? Like, have you found it difficult to like help in that area with housing with most families in that area?
Yes, definitely. We do have a homeless outreach program that we operate, and you can imagine what one of the difficulties there is. The amount of money that they get hasn't really changed, but has the cost of housing changed? You betcha. So yeah, that's very difficult. We also provide housing in the adult world. Like this is a good example. I think the official open date is next month for a reentry housing that we've been able to develop. And so we're trying to, help in that way as well. But yeah, it's a challenge.
For the housing program, do they have to be enrolled? Do they have to have services?
For the homeless outreach, no, they do not. The only real criteria there is that they have to have a child in the
One of the things you mentioned both at the end about like getting leadership and management bought in. I guess could you talk a little bit about how you all approach that? Because I think that is something that's really important for a lot of organizations and agencies to think about because you're right. The evidence-based programs are excellent, but they're very expensive, they're time consuming, it's a lot of training. So how did you all, negotiate that?
I think really we got in one sense lucky because that's just something that our leadership has always been pretty passionate about. So that's one. Two, I think having people in leadership roles who have been on the front lines is huge because they have an extra understanding of what it is that we're doing and what that's like and what the needs are. So when you approach someone and say, here's what I've got, they can kind of understand where you're coming from. And then things like the clearinghouse are great because that research is all done. It's easy to show somebody this is what we're trying to do. But yeah, we actually, with one of our more recent grants, because we have a CCBHC grant, one whole position was to help develop workforce and do trainings and things like that. So we've definitely seen an investment there. And there's other good benefits too. I mean, we know there's a benefit to the children, to the families, to the community, to the staff. And not just that you're educating the staff, but that's good for retention as well. Our retention levels are lowest now than they have been in years, probably well before COVID, honestly, at this point. And I think that's another piece of it. When you have so many opportunities of learning and support, people like to stick around.
Yeah.
And as therapists, we want to see our clients get better, right? That's what we're all in this for. We all want to see them get better. And when you can have a model that works and that they're going to get there, that feels good.
Yeah, I think that's a really important piece. For sure.
Yeah. And we've had even other staff who weren't necessarily clinical staff comment. I'm thinking support staff in particular at the front desk who heard that child screaming that Kendra's talking about and things. And then they see the child come weekly and a couple of weeks later, they see that screaming child instead walk in quietly and go have a seat. And what are they? Wow, that worked. Now I'm supportive, right? I see it too. So it's really nice.